start the first session. Dr. Sandhya Yadav, she will present a case of gonococcal ophthalmia neonatorum, a rare case report in this era. Please come.
Good afternoon, everyone. Myself, Dr. Sandhya Yadav, final year postgraduate trainee, here presenting a rare case of gonococcal ophthalmia neonatorum. Introduction. Gonococcal ophthalmia neonatorum usually occurs due to vertical transmission to newborn during delivery by women with Neisseria gonorrhea. Untreated gonococcal ophthalmia neonatorum can result in severe ocular conditions including corneal scarring, ocular perforation, and blindness. Case report. A 4-day-old child resident of Morigaon, Assam presented with mucopurulent discharge from both eyes which was associated with redness and bilateral periorbital swelling since 1 day. There was associated excessive crying, irritability, and poor feeding of child. There was no history of fever, cough, any nasal or ear discharge. There was no history of any ocular trauma during delivery or instillation of any eye drops or massage of eyes after birth. Birth history. The child was third child of non-consanguineous parents delivered at term through normal vaginal delivery at local PHC. Birth weight was 3000 gram. Child cried immediately after birth and breastfed. There was no history of any premature rupture of membrane or instrumental delivery. There was no history of any NICU admission, and there was no prior history of recurrent abortions or stillbirths. Past history of parents. Mother gave history of vaginal discharge during first trimester of pregnancy for which no treatment was taken. There was no history of any chronic illness in mother. Only first antenatal visit of mother was done. Father also gave history of off and on urethral discharge from last 1 year, but both parents refused any history of multiple sexual partners. This baby came with us on day 1 with bilateral mucopurulent discharge with mated eyelashes as we can see in the first picture, and there was bilateral periorbital edema and redness. On examination, child was alert, active, feeding well at the breast. The length of the child was 48 centimeter, head circumference 32.4 centimeter. Pulse rate was 116 beats per minute, respiratory rate was 34 per minute. On ocular examination, there was copious yellowish discharge from both eyes along with edematous eyelid. Conjunctival congestion and chemosis were also present. However, the cornea was lustrous and clear. There was fundal glow was normal in both sides. Skin and rest of the systemic examination were normal. For that child, we did conjunctival swab for gram staining, KOH mount, and culture sensitivity. The smear from pus revealed presence of intracellular gram-negative diplococci and few pus cells were there. So culture was done on chocolate agar and a selective medium like modified Thayer-Martin medium, which we can see there were small gray-white mucoid lesions. Sepsis screening was done using blood culture. It was negative. Rest of the investigation, VDRL, RPR, HBS antigen were all negative. Endocervical swab of mother and urethral discharge from father also confirm the diagnosis, and it also shows gram-negative diplococci. Treatment, we started with the saline lavage every 2 hourly till we could see the discharge in that child. Injection cefotaxime 150 mg IV BD was started. Eye drop azithromycin was given 2 hourly in both eye. Eye ointment azithromycin thrice daily in both eye. And child usually showed improvement in around 7 days. Parents were sent to STD clinic where they were started with kit 1 and kit 2. Discussion. Child presented with thick profuse mucopurulent discharge and tense eyelid edema with marked chemosis, and the symptoms subsided after 5 days with medical treatment. Infected women should be treated during pregnancy and should be retested after treatment to ensure therapeutic success. Without preventive measures, gonococcal ophthalmia neonatorum can occur in 30 to 50% of infants which are exposed during delivery. Conclusion, This is a medical emergency require immediate hospitalization. If left untreated can lead to severe visual complications, and it can be like prevented in 3 ways, like if we go for selected treatment of expectant mother via prenatal screening, blanket prenatal antimicrobial treatment of all expectant mother, as well as postnatal application of prophylaxis to all neonates within the first few hours after birth. Thank you so much.
Thank you very much. What was the dose you had total of cefotaxime?
So we have started with 50 mg, total 150 mg BD we have given. We have, child was 3 kg, so we have started with 50.
50 mg per kg per dose.
So like 150 mg BD was started.
Per dose approximately, huh?
Yes, a total 300 we have given per day.
So here you have to use systemic antibiotics. Topical antibiotics, they don't suffice.
Yes, sir.
In our days, we used to give penicillin drops.
Now
Every-
resistance.
Every 5 minutes for half an hour, then every half hourly, like that. Your schedule was like, it used to like this. Thank you.
Okay, thank you, sir.
So azithromycin is the latest, as she has told. I don't know. Next, Dr. Ashwini Kumar. Yes, please. Your topic, sir? Visual rehabilitation. Please, I will need the other mic. Mic or something. अभी इन्होंने दूसरा मार्क्स का, ये तो नॉन कॉम्पिटिटिव सेशन है, वो प्रीपेपर सेशन है. Can I start? Yes, sir, please start. No, moment. Hello, आवाज आ रही है? उसका स्लाइड चेंज करें. Yeah, I'm Dr. Ashwini Kumar at Mahavir College, Patna. So basically, I started the visual rehabilitation part 5 years back. In fact, basically, I was a surgeon before, but I got paralyzed 13 years back. So I couldn't operate with the one hand. So I went to Shankar Desai and learned the slow vision aid, visual rehabilitation. So during that, I saw that very few people could afford the low vision aids because they were very expensive. So I invented the household items like changing the color contrast. I go to the patient's room, I told them how to do this thing, like normal day-to-day activity. Like they can't make the routine with one hand on the magnifier. So I somehow went to their home and changed the color contrast of the room and all. So with a different item, so I'm starting now. It's been 5 years I've been doing this. So household item. I conducted a experimental study by, it was attended by 55 low vision patients in Patna in the month of November 2021. Consent was taken and research was taken from all subjects. No invasive technique was used. As majority of patients were poor socioeconomic ground, common household items are used to help patients with low vision aid to manage their daily activities. On follow-up, majority of the patients expressed satisfaction and ability to perform simple day-to-day tasks. The researchers recommend usage of these items in low resources settings. Like you can see there is a bell-shaped distribution of patients who participate in the research. The majority of the subjects in the second to 5th decade of life. Only 1/5 of the subjects were female and 4/5 were male. While the subject comes from a variety of occupational backgrounds, most of the patients attended the clinic were poor and they are based in the Mahavir College run by charitable trust. So 25 patients were retired, 13% were students and 4% were home makers and rest were others. The visual aspects of the subjects were overwhelmingly poor and had limited scope of correction using lenses or glasses. Well over half had visual acuity poorer than 616 both eyes. They all complained of inability to perform daily tasks and unable to perform surgery, medication, or use of spectacles. The subjects all reported difficulty with performing common household tasks. However, it was surprising that majority complained that about inability to view mobile and watch television as the causes of highest concern. Other prominent causes of concern were writing and moving outside their home. A variety of household items were developed at home were recommended for use for the patient. Over 30% reported that the cardboard tool for the county currency, as you can see, it's called the Notex. It has prevention. You can just feel the cut marks and remember the denominations. Then I use, like you can see the boil, this, sorry, previous one. As you can see the smallest, this is signature guide. As you can see in this slide, you can see a cardboard is made. I give it to the patient to practice at home. So they practice at their home how to make the signature, the chart, check and all. And another one is Notex. So we help patients in the kitchen, school, household movement, outside walking. Then I told them how to walk, like it's called M training. Patient will make a capital M by rotating his neck when he had problems in the facial breathing. So all these are different tasks I use to help patients with the low vision rates. Thank you so much.
Thank you, sir. Thank you very much. It is really commendable that he is working. He has adopted a new field of work because he cannot do it now. So thank you very much, sir.
Yes, sir. Thank you, sir. Sir, I have got the second life, sir. I have got a second life. And lots of people paid for me, so it's my social responsibility to help करे सब लोग की. नहीं sir, I am very junior, sir.
Rare case of adult motile form anterior chamber in limited source setting. Please give your full introduction, your place of work.
Yes, sir, definitely. संध्या कुमारी. Good afternoon, everybody. I would like to thank AOS for giving me this opportunity.
Dr. A.B. Sahai, Dr. Nilesh.
Okay. Yeah, the topic of my presentation, I'm Dr. Sandhya, I'm a fellow at Akhand Jyoti Eye Hospital, Bihar, and today my topic of case is managing a rare case of an adult motile worm in anterior chamber in a limited resource setting from Bihar. A filarial worm is a natural parasite of the domestic and wild animals. Humans are accidentally infected. It is mainly a disease of lymphatic system, and it rarely presents as intraocular filariasis in otherwise asymptomatic patient without any constitutional symptoms. The most common clinical presentation of ocular filariasis is chemosis, lid edema, orbital cellulitis, anterior uveitis, or worm in the anterior chamber. Our case is he is a 31-year-old male patient presented in our OPD with pain, redness and swelling of the lids with decreased vision in the left eye for 4 days. The similar history is present in the left eye for last 1 month. He was previously on anti-parasitic medication for last 5 years, but stopped for now, and there is no supporting relevant document was available. His best corrected visual acuity in the right eye is 6.6 and left eye 660. His IOP on GAT was 11 and 40. On examination, slit lamp examination, right eye was within normal limit, and in left eye, conjunctiva got circumciliary congestion, cornea got haze, and in anterior chamber, a long coiled opalescent active motile worm was there. Pupil was mild, mid-dilated and sluggishly reacting to light. Lens was clear and fundus was within normal limit. This is the motile worm in the AC. Here it is a video where I can show you how it was moving when I was capturing it. Yeah, this is the motile worm. Surprise, fundus and OCT macula was normal. So a provisional diagnosis of unilateral secondary uveitic glaucoma with a live intraocular parasite was made. On systemic examination, elephantiasis of right leg with skin discoloration was there. Hydrocele was present. There is no history of fever or swelling around the eyes. No enlarged lymph nodes were found. His complete blood count and erythrocytic sedimentation rate are within normal limits. No eosinophilia was there. On PBS also no microfilaria was detected. No ova adult worm found on stool examination.
Medical, we started him on oral steroids, eye drop prednisolone 1 hourly, timolol BD, and we gave intravenous mannitol 20% and planned the surgical removal of the worm next day. Surprisingly, what happened on the next day, we got the patient was complaining of pain, but worm was not present in the anterior chamber. We did the gonioscopy, and then we found that the worm was coiled on itself, and it was lying still in the anterior chamber. This is, I can show you here inferiorly. It is lying on the slit lamp examination, and in the gonioscopy, we can find the long coiled worm in the AC. We took him to the OR, then a nasal side port was made. Then we able to detach the worm from the angle by Sinski hook, and worm was freely floating in the anterior chamber after putting the viscoelastic substance in the interior chamber. This is the worm removed in toto. Considering the diameter of the cornea, it got the triple size of the corneal diameter, but the worm was so fragile and we could not able to measure the length with the help of caliper. The dead worm was preserved in formalin, and we sent it to the microbiology lab for its identification. On the first postoperative day, mild conjunctival conjunction with corneal edema was there. Anterior chamber got mild reaction. We have we have continued the same preoperative management, and after 1 week, we found the eye to be quiet, and left eye vision got 6/6 and N6. However, as the worm was swollen and fragile, microbiological investigation did not confirm the subspecies of the filarial worm. We referred him to the general physician for regular follow-up. These are my references. Thank you.
Thank you very much, Dr. Mali.
Yes, sir.
It is a live experience for us to see a worm in the anterior chamber. Thanks for showing that worm.
Yes, sure, sir. Yes, sure. When? So we tried for both. Means in the morning also we sent the sample, and the night also we took the sample, but inconclusive. Yes, sir. Sir, actually this is a provisional diagnosis we made on the basis of means filarial elephantiasis. Yes, sir. So we have sent him to the general physician for opinion, and yes, sir, we are following him. He's taking parasitic medication, diethyl carbamazepine. He's taking that. Yes, sir. Okay.
I thought you are one of these co-creators. Thank you, madam.
Yeah, thank you, sir. Any question?
In 1981, I was working in Civil Hospital in Jammu and Punjab, and I did a lot of surgeries for the hydrosleeve, because a lot of people from Bihar who were having cardiac arrest, they had massive hydrosleeve. So the surgeon there, they operated once in front of me and said that I will not touch these patients. You have to operate. For 6 months, I was daily hydrosleeve surgery. Thank you.
Okay.
Dr. Sriya, Dr. Ankita, Dr. Almai Bala, please come forward. Dr. Sriya, or Ankita?
Good afternoon, everyone. I'm Dr. Shadma Iqbal from RIO Patna, and will present a case on ocular manifestation of rickettsia. There's no financial interest, there's no conflict of interest. A 16-year-old male who came with complaint of diminution of vision in right eye since 5 days with preceding history of fever. There was no history of joint pain. The right eye ocular examination shows best corrected visual acuity 1/16 right eye, 6/6 in the left eye. Conjunctiva and cornea was clear. Cells 1+ present in the right eye and 2+ present in the left eye. Fundus examination, right eye normal discs with superior temporal and inferior temporal vascular sheathing, and exudates with macular edema and hemorrhages around the macula. In the left eye, it shows the pale disc and superior temporal vascular sheeting, and hemorrhages in the superior temporal quadrant, along with the retinitis lesion. Investigations were within normal limit. We suspected this as a case of epidemic retinitis and carried on a dengue serology test, which came out to be negative. But we carried on the wheel Felix test, which showed the positive titers for typhus group and spotted fever group of rickettsia. Fundus fluorescent angiography was done, which showed the vascular leakage and disc leakage, which was suggestive of vasculitis in right eye as well as left eye. This is OCT of right eye showing the subretinal fluid, and in left eye showing full thickness retinitis lesion. This is OCT showing vitreous cells in the vitreous, which is suggestive of vitritis. We started the patient on tablet doxycycline 100 mg BD for 1 week, then OD for 2 weeks, along with tablet omnacotil and topical steroid with topical Midriatic. On subsequent visit, vision improved to 6/36 in right eye and 6/6 in left eye. This is a follow-up fundus image of the patient, right eye, which showed the resolving hemorrhages, resolving sheathing, and decreasing macular edema. And the left eye showing resolving retinitis lesion and resolved hemorrhage. This is 1 month follow-up OCT showing resolving subretinal fluid in the right eye and resolving retinitis lesion in the left eye. 3 major categories of rickettsial agents: the spotted fever group, the typhus group, and the scrub typhus. This is endemic in many states of India like Rajasthan, West Bengal, J&K, Kerala. The systemic involvement is characterized by triad high fever, rash, and general malaise associated with headache. The ocular findings of rickettsia is conjunctivitis, keratitis, uveitis, retinovascular changes, retinitis, as well as optic nerve involvement. The vasculitis is the basic pathogenic mechanism, and the deposition of immune complexes and inflammatory cells in the retina, which will lead to the formation of white infiltrates. A suspected clinical case showing titers of 1:80 or above in OX2, 19, and OXK antigens by Wheel Felix test and optical density greater than 0.5 for IgM by ELISA is considered positive for typhus group and spotted fever group of rickettsia. And the gold standard tests are immunoperoxidase assay and IFA. The treatment is, early treatment is critical to outcome and must be started on the basis of clinical diagnosis. The doxycycline is the drug of choice, whereas when doxycycline is contraindicated, azithromycin and clarithromycin can be used. Systemic steroids is used for in cases of extensive retinitis, serous RD, macular edema, retinal vascular occlusion, and optic neuropathy. So to conclude, the clinical clues to diagnose ocular rickettsiosis is multifocal retinitis, predominantly involving the posterior pole. Systemic fundus examination should be a part of the routine evaluation of any patient who presents with fever or skin rash living in or returning from a specific endemic area. Thank you.